Welcome back to another episode of This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar, and as always, thank you for tuning in. Now, a quick note before we begin. We didn't have an episode last week. Many of us were at the ERS meeting in Amsterdam, and between presentations, networking, and the sheer pace of new science, it was a full schedule. But that's the reality of our field, right? We're constantly balancing the clinic, the ICU, research, and conferences. This week, we've got something a little different. Instead of 3 original trials, I'm bringing you 2 brand new clinical guidelines and 1 landmark randomized trial. First, we'll walk through the European Respiratory Society's new guideline for adult bronchiectasis. Then, we'll look at the CLEAR trial in the New England Journal of Medicine, which tested hypertonic saline and carbocisteine in bronchiectasis. And we'll finish with the American College of Chest Physicians' new guideline on biologics for severe asthma. Remember, everything here is for education. Please use your judgment and read the full publications before applying anything directly to patient care. All right, let's get into it. The first highlight this week is the European Respiratory Society Guideline on the Management of Adult Bronchiectasis, published in the European Respiratory Journal. Bronchiectasis has often been called the neglected disease, common, burdensome, but historically under-researched. This new guideline updates the 2017 version and reflects a huge growth in trial data and registry evidence over the past decade. The task force reviewed evidence using the GRADE approach and built recommendations around 8 key clinical questions. Let's talk through the big takeaways. First, airway clearance techniques. The panel makes a strong recommendation that every patient should be taught airway clearance, not just those with sputum, but even those with dry cough and CT evidence of mucus plugging. The evidence is low certainty, but the clinical rationale is strong. Techniques should be individualized: oscillatory devices, autogenic drainage, active cycle of breathing. There's no single winner. Second, pulmonary rehab. Again, a strong recommendation. If the patient's exercise capacity is impaired, rehab should be offered, just as we do in COPD. Third, exacerbation prevention. Here the panel comes down firmly on 2 interventions: long-term macrolides and inhaled antibiotics. For macrolides, azithromycin is the workhorse, 250 milligrams daily or 3 times a week, or 500 milligrams 3 times a week. But crucially, non-tuberculous mycobacteria must be ruled out before prescribing to avoid resistance. Inhaled antibiotics are strongly recommended in patients with chronic Pseudomonas aeruginosa infection and at least 2 exacerbations per year or 1 severe one. The guideline also conditionally supports inhaled antibiotics for other pathogens. Fourth, mucoactive drugs. These are only conditionally recommended, and the panel specifically advises investigating against recombinant DNA, which works in cystic fibrosis but can worsen outcomes in non-CF bronchiectasis. And importantly, what not to do. They recommend against long-term non-macrolide oral antibiotics as first line, and against inhaled corticosteroids as routine therapy. That's a big shift. Many patients still end up on ICS just because of chronic airway disease, but the evidence is weak and the risks are real. Beyond treatments, the guideline stresses a structured workup for underlying causes and comorbidities. About 40% of bronchiectasis cases have no clear cause, but when we do find one, autoimmune disease, immunodeficiency, ABPA, management can change significantly. So what's the takeaway for the clinician at the bedside? If you see a bronchiectasis patient, think about 4 pillars: airway clearance, pulmonary rehab, macrolides, and inhaled antibiotics for high-risk patients. Avoid ICS, avoid non-macrolide oral antibiotics, and only use mucoactive drugs selectively. My commentary? This guideline matters because it standardizes care. In some clinics, patients still get very little structured management beyond keep the chest clear. Others are loaded up with inhaled steroids and multiple nebulizers that don't help. This guideline puts us all on the same evidence-based page. It doesn't solve everything. The evidence is still moderate at best in many areas, but it's a step toward consistency and better patient outcomes. The second piece this week is the CLEAR trial, published in the New England Journal of Medicine. This study really tests one of the areas the guideline flagged as uncertain, mucoactive therapies. So what did they do? They enrolled 288 adults with non-cystic fibrosis bronchiectasis across 20 UK centers. Patients had to have daily sputum production and at least one exacerbation in the past year. They excluded smokers and anyone who had recently used a mucoactive drug. It was an open-label 2x2 factorial trial. That means patients were randomized to hypertonic saline, carbocisteine, both or neither, with everyone getting standard care. The trial ran for 52 weeks, and the primary endpoint was the number of pulmonary exacerbations. The results were clear and negative. Hypertonic saline, 0.76 exacerbations per year. No hypertonic saline, 0.98. That's a difference of minus 0.25, but it wasn't statistically significant. For carbocisteine, the numbers were 0.86 versus 0.90, essentially identical. Secondary outcomes were also flat. Time to next exacerbation, no difference. Quality of life, no difference. Safety events including serious ones, similar across all groups. So what do we do with this? Many guidelines, including the old ERS recommendations, suggested mucoactive drugs as a way to improve sputum clearance, and in practice, about 28% of bronchiectasis patients worldwide are on them. CLEAR suggests we may not be helping. The trial doesn't mean no one benefits. Some individual patients do feel symptomatic relief with hypertonic saline, but as a population-level intervention to prevent exacerbations, it doesn't hold up. From a bedside perspective, that means we can be more confident in deprescribing. If a patient is struggling with multiple nebulizers and the burden of therapy, and you're not seeing clear improvement, there's little justification for pushing mucoactives purely for exacerbation prevention. My commentary? This is an important negative trial. It will likely shift guidelines away from recommending routine mucoactive therapy, and it's a reminder that interventions that make sense in theory, thinning mucus, stimulating clearance, don't always impact the outcomes that matter most to patients. We should keep focusing on exacerbation prevention, but look beyond mucoactives to interventions with stronger evidence. The third update this week comes from the American College of Chest Physicians, published in Chest. It's a new guideline on how to select biologics for severe asthma. Severe asthma makes up only 5 to 10% of the asthma population, but those patients account for nearly half of the costs, the hospitalizations, and the morbidity. Biologics have changed the landscape. Omalizumab, mepolizumab, benralizumab, dupilumab, tezepelumab, but the big question is, which one do you choose? The panel used the GRADE approach to systematically review the evidence and came up with 7 recommendations. Here's how they frame it. First, phenotype matters. If the patient has eosinophils above 300 per microliter, or FeNO above 25 parts per billion, they're considered T2 high. Those patients respond best to anti-IL-5 drugs like mepolizumab, reslizumab, or benralizumab, or to anti-IL-4/13 drugs like dupilumab. If the patient has allergic asthma, think high IgE, A to B, allergen-driven symptoms, omalizumab is still first choice. For patients with nasal polyps or eczema, dupilumab can hit multiple pathways and deliver added benefit. And then there's tezepelumab, the anti-TSLP drug. What makes it unique is that it can work even in patients without the typical T2 markers, the so-called T2 low group, who otherwise don't have great biologic options. The guideline also emphasizes patients on chronic steroids. For those who are steroid dependent, biologics should be prioritized early with the goal of reducing steroid burden. Now, the elephant in the room. There are still no head-to-head comparative trials. Every recommendation here is based on indirect evidence. So while the framework is strong, we're still left making decisions in the gray zone. At the bedside, this guideline helps us be more systematic. Don't pick a biologic randomly. Match the drug to the patient's biomarker profile, comorbidities, and exacerbation history. And wherever possible, move away from steroids and toward biologics sooner rather than later. My commentary? This is a guideline that reflects real-world practice but codifies it in a way that should reduce variability. The next step, and what we really need, is comparative effectiveness trials. Until then, this is the best framework we have. And that wraps up this week's episode. We covered the ERS Guideline for bronchiectasis, which gives us a structured roadmap for management. We looked at the CLEAR trial, which suggests mucoactive drugs like hypertonic saline and carbocisteine don't actually prevent exacerbations. And we reviewed the CHEST Guideline for biologics in severe asthma, which gives us a framework for matching drugs to phenotypes. I hope this helps you stay up to date without needing to read hundreds of pages of guidelines and trial data yourself. If you found this useful, share it with your colleagues, subscribe, and leave a comment on what you'd like us to cover next. Until next time, stay evidence-based, stay curious, and I'll see you in the next update.